Today we are going to study about one of the infectious disease of childhood, that is tuberculosis. Okay, so this is also a respiratory infection. So let's see in more detail regarding tuberculosis. So tuberculosis is an infectious disease which is mainly caused by the organism Mycobacterium tuberculosis. And this Mycobacterium tuberculi, usually it's affecting the lungs, but apart from that, this can also infect the other body parts like your meninges, brain, stomach, etc. So today's class we are going to study in detail about the pulmonary tuberculosis in children. Okay, so let's see about the etiology. So as I already said you, the tuberculosis is mainly caused by a gram-positive organism, that is Mycobacterium tuberculosis. And this organism, which can spread from an infected person to a child through cough, then sneeze, spit, laugh, or talk, etc. At the same time, tuberculosis is a highly contagious disease. Because of the increased emergence of this disease, antibiotics are also developed to fight against TB. But nowadays, some of the strains of the Mycobacterium they have gained more resistant to these drugs. Okay, so as a result, what happened? Multi-drug resistant TB has been developed. So this case usually arises when the antibiotics fails to kill the bacteria. Understand? Okay, so now we'll see regarding about risk factors. Okay, so children with a compromised immune system. So as you already know, children usually they will be having less immunity. So whenever there are associated disease conditions which can compromise the immune system, which include the child with HIV, then child with any kind of diabetes, childhood diabetes, then child is having any kind of certain cancers. At the same time, those children, those who are undergoing for any chemotherapy, then radiation therapy, child with the malnutrition, kidney disease are also very risk for developing the diseases. Okay, now we are going to learn regarding the pathophysiology of this pulmonary tuberculosis. Okay, so usually the tuberculosis infection which will begin when these organisms in the sense these Mycobacterium tuberculi, they reach the alveolar air sacs. Okay, so in the alveolar air sacs, these organisms will invert and they will replicate over there over the alveolar macrophages. Okay, so usually you know the functions of the macrophages. So usually what's their function? They will identify the bacteria as the foreign substance and they will try to kill it by the phagocytosis. So here also the same process will happen. Once the mycobacterium gain an entrance to the alveolar macrophages, the alveolar macrophages will identify this bacteria as a foreign substance and they start their processing of what phagocytosis. But imagine here the Mycobacterium tuberculosis, which is having a very thick mycolic acid capsule over their surface. So, because of the presence of these capsules, these Mycobacterium tuberculi can easily escape from the phagocytosis. Okay, understand? So, the presence of a waxy mycolic acid capsule will protect these Mycobacterium tuberculi from the process of phagocytosis and slowly they will start to kill the macrophages. So they are gaining access to the respiratory tract and they are getting escape from the phagocytosis and slowly they are trying to kill the immune cells. Okay. So here the primary site of infection will be always lungs, which is known as gone foci. Okay, so this gone foci is usually located in the upper part of the lower lobe or the lower part of the upper lobe. So this is a normal position where this gone foci is situated. At the same time, the tuberculosis of the lungs can also occur through the infection that is happening from the bloodstream or elsewhere from the body. So if the organism is present elsewhere in the body, they can flow through the blood and lymphatics and they can reach the where the lungs and they can also start the infection. And this infection will be leading to various kind of clinical manifestations in the child. Okay, understand. So now we are going to study regarding the clinical manifestations. So usually the child will be having the complaints of fever, then malaise will be there, and anorexia will be there, and the child will be having weight loss. Okay, and usually in the initial stage, the child doesn't develop any kinds of cough, or sometimes the cough may be present, or sometimes mostly the cough may not be present, and it will be developed over the time. It will take around 1 to 2 months for the child to develop into a chronic cough. Okay, and they will be aching pains. The same time, chest tightness will be there, and followed by the cough, the child will be having the complaints of hemoptysis. Okay, and increased respiratory rate will be there. And in some children, if you assess, you can see some palpable masses over their neck. That is also a clinical manifestation. Then poor expansion of the lungs on the affected side. Then if you do an auscultation, the breath sounds will be diminished, or they will be absent breath sounds, or crackles can be heard because of the increased amount of secretions. And if you do a percussion, you can usually hear the dullness sound. Okay, then there will be a persistent fever, then generalized symptoms will be there, then the child will be having the complaints of pallor, anemia, then weakness, weight loss, and lethargy, and reduced play activity, etc. So these are the major clinical manifestations you can notice in a child. Okay, and we are moving to the diagnostic method. How we can diagnose pulmonary tuberculosis in the children. Okay, so here the usual step we follow is the history collection. So history is collected from the family members regarding is there any present positive cases of tuberculosis in the family, or any first degree, second degree relatives, because this is a hereditary also, this disease can transmit. And the history of their workplace and the parents' occupational history, whether they are health workers, all this history need to be collected. The next one is regarding the physical examination. So in the physical examination, the nurse has to monitor for the uh, symptoms in the child. At the same time, the nurse can assess for a neck mass, neck swelling, like severe persistent weight loss, that then symptoms of pallor, everything can be assessed. Then the next common diagnostic method usually we follow is a tuberculin skin test. Okay, so that we will be discussing later. The next is a radiographic examination, which include chest X-ray can be taken, and a sputum culture can be sent if we are suspecting any kind of bacterial infection. So these all are the common diagnostic methods usually followed. Now we'll see regarding what is tuberculin skin test. Okay, so this is the most common indicator which is mainly used for the diagnosis of tuberculosis. So here purified protein derivative, that is known as PPD. So that is 5 tuberculin units are injected into using a 27 gauge needle using a 1 ml syringe into the volar aspect of the forearm of the child. Okay, so here I can show you the images. So once the purified protein derivative is injected, creation of a visible wheel is very crucial for the accurate testing. And once the injection is over, the reaction of the skin is measured after 48 to 72 hours. Okay, so once the area after the injection, the area is marked to identify for the reactions. So here the size of the transverse diameter of the reaction, that is known as induration. So this induration is measured to identify the results. Now we'll see how to interpret the results. So imagine after the injection, after the purified protein derivative injection, you are assessing the child's hand after 48 to 72 hours, and induration you are noticed, and which is more than 5 mm. And if the induration is more than 5 mm, you are suspecting the child to have a tuberculosis infection. So in order to make sure that clinical evidence of the disease also needed, for that we need to send the child for a radiographic examination. Okay, so if the induration is more than 5 mm, the child has to be clinically monitored for the signs and symptoms of tuberculosis. And imagine if the induration is more than 10 mm, which indicate that the child is having a high risk for developing tuberculosis. And imagine if the induration is less than 5 mm, which indicate that we need to repeat the test again. Okay, understand? At the same time, once the individual has been came in contact with the bacilli, or once he has been infected with tuberculosis, every time when you check this tuberculin test, the child will be tested positive only. Okay, and if the second time, if you are repeating the test again, and you have found that the child is again having the induration more than 5 which indicate that child is a positive case of tuberculosis. Okay, clear? So this is regarding the interpretation of the test. Coming to the therapeutic management. So the management of the child with the tuberculosis, which include adequate nutrition, then pharmacotherapy, general supportive measure, and prevention of unnecessary respiratory tract infections and allergies, etc. So we'll see regarding doubts therapy. So doubt means a healthcare worker or another responsible person mutually agreed upon the individual who is present at the time of administration of the medications to the patient. So this DOTS is considered one of the cheapest method in order to eradicate tuberculosis. The standard duration is up to 6 months and it may vary upon the condition of the child. The recommended drug regimen for child and adolescents include a daily dose of isoniazid, that is INH, for 9 months, or alternatively 2 to 3 times per week the child has to consume. Okay. Next is regarding rifampicin. Rifampicin daily for 6 months has to be given to a child if the child is isoniazid resistant. I already said you regarding multi-drug resistant tuberculosis are also present. So if if INH is resistant, in such cases rifampicin can be administered to the child. And next is regarding a clinically active tuberculosis. So here our main goal is to sterilize the gone foci. So here the recommended drug therapy include the combination of isoniazid, rifampicin and pyrazinamide. So according to the American Academy of Pediatrics, a 6-month regimen is usually given, which consists of isoniazid, rifampicin and pyrazinamide, which is given daily for first 2 months, followed by isoniazid and rifampicin given 2 to 3 times in a week, followed by a period of 4 months. Okay, so this is regarding the treatment regimen of clinically active tuberculosis. And imagine if the child is a multi-drug resistant TB positive. So if the child suspected to have this multi-drug resistant TB, a fourth medication is also used, that is streptomycin. So streptomycin is usually given as the IM injections. If streptomycin is not available, ethambutol can be given. Okay, and this can need to be continued for a period of 9 months. So isoniazid, rifampicin, pyrazinamide, usually with the ethambutol or streptomycin should be given for the first 2 months period. So this is regarding the multi-drug resistant tuberculosis. Coming to the important aspect, that is nursing management. So airborne precautions and negative pressure rooms are required for the child who is TB infected. Okay, so use of personal protective devices and N95 or N100 masks has to be provided to all children because they are less immune. Then provide optimum nutrition and adequate rest for the sick child. Then tuberculin test has to be conducted at the correct time and the result has to be properly interpreted. Then appropriate collection of samples for culture. So R&DCP programs are available. So the sputum samples need to be sent for the culture. So at the correct time in the early morning, 3 samples of sputum need to be collected. Okay, and chest physiotherapy and postal drainage to be initiated in the children, those who cannot spit out the sputum. At the same time, positioning also can be given in order to drain the sputum from the different lung lobes. Okay. Regarding the prevention of the disease. So the only way to prevent TB is to avoid contact with this tubercle bacilli. So maintaining an optimal state of health with adequate nutrition is one of the important factor. Then pasteurization of the milk and milk products, because from the animals also this tuberculosis can be infected to the human. So milk and milk products has to be pasteurized well in order to avoid the bovine TB. And the preventive measure is administration of BCG vaccine, that is bacilli of calamity and Guru. So this is a live vaccine which contain bovine bacilli with reduced virulence. Okay, virulence means it's the capacity of the organs to cause disease. So here the virulence power is reduced, and this vaccine is given as a single intradermal injection at the deltoid muscle at the time of birth. And it's believed that This vaccine can given a protection rate up to 20 years and the side effects are very less and it is not reported much. Okay, so this is regarding the BCG vaccination. So all these measures will help to reduce the incidence of tuberculosis and RMDCP programs also running very fast in order to reduce the occurrence of this tuberculosis. Okay, so thank you.